Hello, I'm Dr. Shivika Sethi, the Faculty of Microbiology at Marrow. The news of the next has been hovering around our necks for the last 4 years, but there are still no signs of it getting implemented. But sooner or later, this is going to come around our neck and we have to be well prepared for it. So for preparing all our students for attempting the questions which are anticipated in the next exam, here we present to you the clinical edge discussion, and this is the edge discussion of microbiology. Now, quite evidently, this is going to be a discussion of infectious diseases, or I would say infectious syndromes, and these are going to be from a microbiology perspective, right? So basically, I'm going to be presenting vignettes to you of infectious diseases, and we are going to be discussing the diagnosis, the likely organism, some important forget-me-not points regarding that particular organism, and finally, we're going to test our knowledge with a set of MCQs after every infectious syndrome. So let's get going. A 1-year-old girl is brought to the emergency because she has been crying more than usual and refuses to eat. She has not seen a physician or received any vaccinations since birth. On examination, the child is avoiding bright lights, has a temperature of 39.4, cries on neck flexion, has bulging anterior fontanelle. There are no obvious focal neurological deficits. Lumbar puncture is carried out. The CSF analysis shows that the pressure is raised. WBC count is markedly elevated. The protein levels are elevated, but the glucose levels are reduced. So, what are the important points here to register? It's basically a meningitis in a 1-year-old child. Now, let us assess what are the lumbar puncture findings with the help of this table. In a bacterial meningitis, of course, remember the pressure of the CSF is going to be raised in all meningitis. In a bacterial meningitis, the cell counts, we are going to predominantly see polymorphs, which are markedly elevated. So, 1000 to even 5000 per cubic millimeter. Glucose is markedly reduced and proteins are elevated. In case it's a viral meningitis, the opening pressure, an exception, is usually normal. The cell counts are usually the lymphocytes which are elevated, 10 to 500 per cubic millimeter. Glucose levels are normal and protein levels may be normal or elevated. In fungal meningitis, the opening pressure is elevated, lymphocytes predominate, the glucose levels are reduced and protein levels are elevated or may be normal. Tubercular meningitis, the pressure is raised, lymphocytes are predominantly seen, glucose levels are reduced and protein levels are elevated. Now, looking at this table and comparing them with the findings of the child, what would we say? It is a case of bacterial meningitis in a 1-year-old child. And what are the what are the likely causative agents? It is either going to be Streptococcus pneumoniae or it is going to be Hemophilus influenzae. Now, let us see this table here, which is giving us that which are the predominant causes of meningitis age-wise. So, concentrating on this column, we are seeing in 6 months to 2 years, the most common agents are Streptococcus pneumoniae or Hemophilus influenzae, and less often we have viruses like enterovirus and herpes simplex virus. Okay. So, here it is a bacterial meningitis, so we are going to concentrate on these two causes of this meningitis in a 1-year-old child. Let's start with Hemophilus influenzae, which is the likely agent in this case. Why? Because in the question it has been mentioned that this is an unvaccinated child, and mostly this is an infection which is preventable by the HIV vaccine. Okay. So, gram stain picture in the CSF, what are we going to see? We are going to see gram-negative Coccobacilli. So, pleomorphic gram-negative bacilli. And the most likely serotype which is going to be causing this infection is capsular serotype B, which is the most virulent serotype. And it has the most virulence, the most important virulence factor is the capsule. The polysaccharide capsule, which is made up of polyribosylribitol phosphate. Okay. Now, what is the most specific method for diagnosis in this child? It would be culture. And we know that Hemophilus influenzae requires X and V factor to grow. X factor is hemin or any other porphyrin containing compound, and V factor is NAD or NADP. Okay. So, Hemophilus influenzae generally gets both these factors when we grow it on chocolate agar, which contains lysed RBCs, or if we don't have chocolate agar, we can use blood agar with a Staph aureus streak on which it characteristically shows satellitism. Satellitism, okay, very, very important to remember about Hemophilus, that Staph aureus lyses all the RBCs, hence releases the V factor. That's why Hemophilus influenzae will grow just close to the Staph aureus streak. Now, there are other methods for diagnosis of this meningitis in this child. Rapid test for diagnosis, as you can see in this figure, this is a latex agglutination. Or we can do, so instead of waiting for culture or even for microscopy, just do a latex agglutination and you can easily say, yes, this child's CSF is containing the capsular antigen of serotype B. Or of course, we can also do a PCR. Moving on to the treatment. Treatment is going to be third generation cephalosporins. So either ceftriaxone or cefotaxime are going to be used for treatment. The reason is that many strains of Hemophilus influenzae contain or they are able to produce beta-lactamases, which will be able to hydrolyze the first and second generation cephalosporins and penicillins. That's why we use third generation cephalosporins for treatment. Now, of course, we should also give chemoprophylaxis for all contacts of this child, and the drug of choice for chemoprophylaxis is rifampicin. And finally, how are we going to prevent? How can we prevent this meningitis in children? By using the HIB vaccine. What does this vaccine contain? It contains polyribosylribitol phosphate, the capsular antigen, which has been conjugated with a carrier protein, which is either diphtheria toxoid or tetanus toxoid or CRM197, which is derived from Corynebacterium diphtheriae, or a non-toxic toxin of Neisseria meningitidis. It's a non-toxic toxin of Neisseria meningitidis, right? So, we always need to conjugate it to a carrier protein. So, forget-me-not points about Hemophilus influenzae. Its morphology is gram-negative Coccobacillus. There are two types of Hemophilus influenzae, capsulated strains and non-capsulated strains. The capsulated strains have been serotyped into 6 capsular serotypes, and out of which the most virulent one is serotype B. The non-capsulated ones, since they cannot be typed on the basis of the capsular antigen, they are called as non-typable Hemophilus influenzae. We've already talked about X and V factor and satellitism. The most important virulence factor is the capsule. Other virulence factors include pili, outer membrane protein, and it has lipo-oligosaccharide, not lipopolysaccharide. Moving on to the second probable cause of meningitis in this child, pneumococcus. So, gram stain of the CSF in this child would show capsulated gram-positive diplococci. So, they would be seen in pairs, which are lanceolate shaped, flame shaped. And culture will be done on blood agar, and it will show alpha hemolysis around the colonies, and the colonies have a characteristic morphology, Draftsman or carom coin colonies. Now, biochemicals that we must always remember for all streptococci, they are catalase negative. And what is special about Streptococcus pneumoniae, the biochemicals, they are optogene sensitive, which is done as a disdiffusion test. They are bile soluble and they ferment inulin. These three are very, very important biochemicals for Streptococcus pneumoniae. Rapid test for diagnosis, just like Hemophilus influenzae, we can do latex agglutination to detect the capsular antigen, and also we can do a PCR. Serotyping, right, meaning we want to find out of the so many capsular, more than 97 capsular serotypes of Streptococcus pneumoniae, which is the one which is causing this infection in the child. This can be done either by the Quellung reaction the swelling of the capsule in the presence of its anticapsular antecedent, or we can do it by PCR, right? And the most likely, the most virulent Streptococcus pneumoniae, it's serotype 3. Okay, right. Let's see some images related to Streptococcus pneumoniae. This image is showing us the Draughtsman colonies of Pneumococcus, carom coin colonies. This is the optogen sensitivity test. That's the optogen disc. Optogen is also called as ethyl hydrocuprin, and we can see the wide zone of inhibition around this disc. And this is showing us the bile solubility test. That's the turbidity of Streptococcus pneumoniae, and we added a few drops of bile salt. All the bacteria got autolyzed very, very quickly. That's the basis of basically it's increased activity of the autolytic enzymes by adding bile salts. Treatment of this child should be done empirically with vancomycin along with ceftriaxone, keeping in mind that there are some strains which are resistant to penicillin, and the most common mode of resistance to penicillin is altered penicillin binding proteins, altered transpeptidases which do not allow beta-lactams to bind to them. Immunoprophylaxis is done with the pneumococcal conjugate vaccine. There are many of them, 7, 13, 15 or 20. So basically 20 capsular serotypes of pneumococci have been conjugated again to a carrier protein which could be diphtheria toxoid, tetanus toxoid, CRM197 derived from Corynebacterium diphtheriae. The forget-me-not points about pneumococcus: A for alpha hemolysis, B for bile solubility test, C for the capsule, and you can also remember the carom coin colonies, D for diplococci and Draughtsman colonies, E for ethyl hydrocuprin or optogen sensitivity, and F for flame-shaped. Okay, remember the capsule is the most important virulence factor. Okay, let's do a couple of questions. A patient presented with meningitis and the CSF sample was subjected to gram staining and microscopy and appears as shown in the microscopic image shown below. Which of the following characters or tests will be characteristic of this organism? Okay, so this picture is showing us the typical gram-positive cocci in pairs. And what is correct about Streptococcus pneumoniae? That the fact that it is catalase negative and optogen sensitive. Okay, now let's see the options. Oxidase and catalase negative does not ferment ilunin, applies to viridans group of Streptococci. Ferments glucose and maltose but not inulin. This is not relevant to Streptococci. Oxidase and catalase positive and does not ferment maltose or glucose. Even this is not relevant for Streptococci. Okay, so our answer here is option D. A 1-year-old child is brought to the emergency with multiple seizures, fever, headache and neck rigidity. CSF analysis shows low glucose, high protein and many polymorphs. So this is bacterial meningitis. Culture grew pleomorphic gram-negative bacilli. Which is true about the organism? Of course, what are we going to think of? A 1-year-old child, lots of polymorphs. We're going to think of Hemophilus influenzae. And what is correct about Hemophilus influenzae? It shows satellitism around Staph aureus colonies. Okay, let's move on to our next question. A 2-day-old male is brought to the neonatal ICU with fever and poor feeding. The mother reports that the baby has been irritable and difficult to console for the past 24 hours. The infant was born full term via normal vaginal delivery and had an unremarkable prenatal course. On physical exam, the infant is crying incessantly. His fontanelles are tense and bulging and has a fever of 101.5. His respiratory rate is rapid, the heart rate is rapid. There are no obvious focal neurological deficits. So looking at all these important hints to us, what is our diagnosis? This is a case of neonatal meningitis. a neonatal meningitis, and what are the most likely CSF cytology findings? Whenever we think of neonatal meningitis, we immediately think of bacterial meningitis. So we are going to find that there are polymorphs raised, we are going to have a lowered glucose, we are going to have raised proteins. Okay, now what are the gram stain findings? For that, let's find out what are the three most common causes of neonatal meningitis. These are Escherichia coli, Group B Streptococcus, and Listeria monocytogenes. Group B Streptococcus is also called as Streptococcus A galactiae. Okay. Now, the important things to remember about Escherichia coli is that on microscopy, we are going to see gram-negative bacilli. And when we further culture the CSF, we're going to get lactose fermenting colonies on MacConkey, and it is going to be a motile bacterium. Okay. Biochemicals which are applicable for all Enterobacteriaceae, to which Escherichia coli belongs, is the fact that it is catalase positive, but very important to remember is that they are all oxidase negative. Okay. And they are, Escherichia coli is indole positive. It converts tryptophan to indole. These are the important things which are mentioned in the questions. So please remember these forget-me-not points about Escherichia coli or whatever bacterium I'm talking about. Moving on to Streptococcus A galactiae, what are we going to see on microscopy? Gram-positive cocci in chains. And when we culture them on blood agar, we are going to see beta hemolytic colonies. Biochemicals, like all streptococci, they will be catalase negative, and it gives the CAMP test positive, and it hydrolyzes hippurate. The third cause of neonatal meningitis is Listeria monocytogenes. Morphology on gram stain will be gram-positive rods. Important characters to remember is that on blood agar, it is going to be beta hemolytic, and it has a very, very special motility. It has a tumbling motility and it has a differential motility, meaning it is motile at room temperature of 25 to 28, non-motile at 37. Biochemicals, it is catalase positive and it is CAMP test positive, just like Streptococcus A galactiae. Okay, so these were the three important causes of neonatal meningitis. Let's do a question. A 5-day-old infant is brought to the clinic because of vomiting, fever, refusing feedings, and crying more than usual. The physician suspects bacterial meningitis. A culture of the patient's spinal fluids grows gram-negative rod. Which is the best description for the agent most likely causing this infection? So, a gram-negative rod causing neonatal meningitis, we are going to think of Escherichia coli. So, what is correct about Escherichia coli? It is motile and it is oxidase negative. Okay. So, let's see the other options regarding neonatal meningitis. Catalase negative and beta hemolytic. What this would it be applicable to? A group B Streptococcus. Non-motile at room temperature and, this should be motile at room temperature and CAMP test positive. This is Listeria. Okay. Right. This is incorrect. E. coli is lactose fermenting on MacConkey. Gram stain of CSF sediment of a case of neonatal meningitis is shown in the figure. Okay. What are we seeing? We are seeing gram positive and we are seeing bacilli. Right. So, a case of neonatal meningitis with gram-positive rods in the CSF, we are going to think of Listeria. Which of the following would be useful in further identification of the causative organism? Coagulase test, bile solubility, motility at room temperature. That is our answer. This is going to further identify this as Listeria. Important forget-me-not points about Listeria monocytogenes. It's a gram-positive rod and it is unique that it is gram-positive but has endotoxin in its cell wall. It has peritrichous flagellae and these form only at room temperature, not at 37. That's the reason it shows differential motility. It has tumbling motility. It is CAMP test positive and the selective medium for Listeria monocytogenes is PAL-CAM agar. The important virulence factors are listeriolysin, internalin, and ACT-A, which causes actin polymerization. Drug of choice for listeria is ampicillin. Let's move on to our next vignette. A 22-year-old college student is brought to the emergency. His roommates say that he was complaining of severe lethargy and headache and neck stiffness last night. Vital signs are remarkable for a temperature of 104.3, lowered blood pressure, and tachycardia. Physical examination shows an alert male with photophobia. Kernick's sign is positive and there is widespread purpuric rash on his legs and feet. What is this? Most likely this is a young adult with meningitis and there are purpuras on his legs and feet. The first organism that should strike us is Neisseria meningitis. So most likely lumbar puncture findings are going to be PMNs raised, lowered glucose and elevated proteins, and on gram staining, what are we going to see? Gram-negative diplococci. That's what we're going to see on gram staining. These are the gram-negative diplococci of Neisseria meningitis. Okay, that's the typical purpuric rash, which is typically because of the lipo-oligosaccharide of meningococcus. Now, transport medium for Neisseria meningitis, we must always remember, is Stewart's medium, or we can use a modification, the Amy's medium. Culture, here it's a CSF specimen, so we can easily do it on chocolate agar or we can do it on blood agar. Chemoprophylaxis of this person should be done with, we can use several drugs. We can use either ceftriaxone as a single dose, or we can use ciprofloxacin, or we can use rifampicin. So either of these drugs are given as one single dose, but rifampicin needs to be given for 2 days, right? So all his college mates who have been exposed to him should be given chemoprophylaxis. Immunoprophylaxis is available especially for 11 to 16-year-old adolescents. That is in the form of meningococcal conjugate vaccine 4. Okay. So MCV4, which is containing the capsular serotypes of A, C, W, Y. So these are the capsular serotypes of which the capsule has been incorporated and it has been conjugated to a carrier protein. Okay. Now, the most likely serotype in this case would be serotype A, because in India, the most common serotype of Neisseria meningitis is serotype A and treatment is third generation cephalosporins. Okay. Right. Forget-me-not points about Neisseria meningitis. It's a gram-negative diplococcus which is capsulated, and there are 13 capsular serotypes, out of which predominantly human disease is caused by 6 of them, and the most common in India is serotype A. It is a strict aerobe. It is catalase and oxidase test positive. Now, I've purposely written them, especially the oxidase is mentioned in the questions. It has the most important virulence factor is the capsule. Then there are pili, adhesins and lipo-oligosaccharides. So Hemophilus influenzae and meningococcus don't have LPS. They have lipo-oligosaccharide in their cell wall. The transport medium is Stewart's medium and Amy's medium. The selective medium is modified Thayer-Martin medium, which contains the antibiotics very typically cultures Neisseria: vancomycin, trimethoprim, colistin and nystatin. Another medium is New York City medium. Okay, that also contains antibiotics. Let's take our next vignette. A 20-year-old male is brought to the emergency by his girlfriend for a witnessed seizure that lasted for about a minute. He has been complaining of feeling feverish and having a headache for the past few days. His girlfriend states that he has been forgetful and not been acting like himself. The patient appears confused and lethargic during the interview. Vitals show a temperature of 102, a blood pressure almost normal, a heart rate slightly elevated. you plan to do a lumbar puncture. Now, points to register out here. It's a 20-year-old male who has had a seizure, has become forgetful, having headaches, not acting like himself, okay, and has, and otherwise the vitals are normal except for a raised temperature. What CSF findings would you expect here? Now here, this vignette is not talking about anything about related to neck rigidity, Koenig sign positive, and plus the patient is appearing confused and lethargic, not acting like himself. So this is pointing more towards a diagnosis of encephalitis. Encephalitis. Okay. And what is the most common cause of encephalitis we are going to think about here? We are going to think of herpes simplex encephalitis. That is a viral encephalitis. So the CSF findings are going to be those of a viral cause, right? So we're going to have an almost normal pressure. We're going to have raised lymphocytes. We're going to have normal or elevated proteins, and we're going to have a normal glucose, right? So those are the likely CSF findings in this case of encephalitis, okay, right? So diagnosis is encephalitis, likely causes, the most common cause, herpes encephalitis, in which the serotype 1 predominates. 95% of them is caused by serotype 1, okay? So, forget-me-not points about herpes encephalitis, very, very often asked topic. It belongs to the family herpes viruses, more common cause. Please remember, properties, they are enveloped, icosahedral, double-stranded DNA viruses. The most common lobe affected in this encephalitis is the temporal lobe. So, patient has speech abnormalities, memory problems, hallucinations, becomes aggressive. Diagnosis is best done by CSF for PCR, and treatment is acyclovir for 2 to 3 weeks. Another very common cause of encephalitis in our country, that's the endemic area for Japanese encephalitis that includes our country. In our country, it's the most common cause of epidemic encephalitis. So we must always remember, again, it's a very commonly asked question. What are the forget-me-not points about Japanese encephalitis? It belongs to the family Flaviviridae, which are RNA viruses. These are enveloped, positive sense, single-stranded RNA viruses, which are icosahedral. Vector is Culex species. Natural reservoir is aquatic birds, which are also called as ardid birds or water birds. So these include herons, egrets, cranes, okay? And amplifying reservoir is pigs. Very important to remember. Humans and horses are dead end hosts. Okay. The vaccine strains for Japanese encephalitis include the Nakayama strain, the Beijing 1 strain, the SA1414-2 strain, and the Kolar strain. Okay. Let's take up a question. A patient was brought to the emergency with high-grade fever, headache, neck rigidity, altered sensorium. The patient had seizures in the hospital and was provisionally diagnosed with herpes encephalitis. Diagnosis can be confirmed by which of the following? Our answer is going to be CSF PCR. This option, please remember, Zank smear is never done on the CSF. It is done on the skin lesions of herpes or skin lesions of varicella, not in the CSF. We're going to see multinucleated giant cells. Next vignette, a 12-year-old boy is brought to the school psychologist by his class teacher as he has become irritable, increasingly irritable and forgetful, with a decline in his school performance. On being unable to find the reason, she asks his parent to get a medical opinion. However, even after consultation of many doctors, the cause of his symptoms could not be identified. After several months, the boy started experiencing seizures and twitching in his limbs. His speech became slurred and he had difficulty in walking. His parents took him to a neurologist who ordered an EEG that showed periodic high voltage discharges. The neurologist explained to the parents about a viral etiology and extremely poor prognosis of the boy's conditions. What are you going to form? What opinion are going to form looking at this picture? So it's a 12-year-old boy who's gradually becoming forgetful and irritable. This decline in his school performance, seizures and twitching, speech slurring, difficulty walking, and it's a viral etiology with poor prognosis. What are all these symptoms pointing to? It is subacute sclerosing panencephalitis, which is due to a defective measles virus, a persistent infection due to a defective measles virus. Okay, so that's what the patient typically presents with initially. Usually this is seen in children who have measles less than 2 years before, within the first 2 years of life. That's the typical history. Okay, so decline in gradual mental, intellectual deterioration, then seizures, myoclonic jerks, then speech becoming slurred, and typical, the CT scan or MRI will show demyelination, especially in the white matter of the cortex. And confirmation can be done also by demonstration of IgG antibodies. Or let's not go into the class of the antibody. We detect anti-measles antibody in the CSF. Anti-measles antibody in the CSF of the patient. High titer of anti-measles antibody in the CSF. Okay. So measles virus, remember, it belongs to the family Paramyxoviridae, properties of which are enveloped negative single-stranded RNA, and these are helical symmetry. All paramyxoviruses have special glycoproteins on their surfaces. These are the hemagglutinin. Measles virus has the hemagglutinin and the fusion protein. Typically, what are seen when measles occurs, there is a rash which starts from the forehead and behind the ears and then spreads downward. But before the rash appears, the patient has a prodrome which is characterized by coryza, cough and conjunctivitis. 3 C's: fever, coryza, cough and conjunctivitis. And some children have the typical Koplik spots in the oral mucosa, especially around the first or the second molar teeth. The macular rash we've already talked about. Wardenfink-Keldy cells are seen on lymph node biopsy in a patient of measles, and the vaccine strain is the Edmonston-Zagreb strain. It's used as a live attenuated vaccine administered with mumps and the rubella vaccines. Let's take our next vignette. A 37-year-old is brought to the physician with a history of unsteadiness for the last 2 to 3 weeks. Past medical history is significant for rashes all over his body, including the palms. Whenever you have a rash over the palms, there are very few conditions. One is syphilis, the other one is Rocky Mountain spotted fever, and the third one is hand, foot, mouth disease. Okay, and small nodular lesions in his axilla, to which he did not pay much attention to. So this is immediately thinking with the rash on the palms and small nodular lesions in the intertriginous area. What are these? These are the condylomas of syphilis. So this is a patient who has presented with ataxia. Physical examination shows vitals in the normal limit, but diminished reflexes, loss of coordination. The Romberg test is positive. His pupils are bilaterally small and constrict when he focuses, but not in the presence of light. What are these? This is Argyll-Robertson pupil, right? And this is Romberg sign telling us this is sensory ataxia because of loss of proprioception, and of course the diminished reflexes. This is basically what is our diagnosis looking at this. The diagnosis is tabes dorsalis, which is one of the manifestations of tertiary syphilis. Okay. MRI findings, there is the dorsal root. Dorsal columns of the spinal cords are affected. Okay. So that's the typical manifestation of TBs dorsalis. A couple of more what can be seen is, yes, bladder disturbances in the form of bladder incontinence can be seen. So what are you going to do on this patient to further confirm the diagnosis? The typical history is there, the manifestations are there. You can put up the VDRL test, which can be positive even in the tertiary stages, but not in all cases. This VDRL is followed up with the TPHA or TPPA, whatever is available in the laboratory. So, screening by VDRL followed by a confirmation by TPHA or TPPA. CSF antibodies, better to detect is VDRL, or we can do the FTA-ABS. VDRL is more specific on the CSF specimen than FTA-ABS test. Okay. Now, treatment, what are you going to give benzathine penicillin for this diagnosed patient of neurosyphilis? No, we are going to give aqueous crystalline penicillin for 10 to 14 days. That's our treatment, aqueous crystalline penicillin. And suppose this patient is allergic to penicillin, there is no better treatment than penicillin. So you're going to desensitize this patient and treat with penicillin. Okay, so let's take up another vignette. A 46-year-old man presented to his physician with complaints of sudden blurred vision, headache and confusion. Symptoms started a day before and he was admitted to the hospital for further evaluation. 2 days into his stay, he developed seizures. After stabilizing him, an MRI of the head was done, which demonstrated several scattered ring-enhancing lesions. This patient history is significant for HIV infection. So, an HIV infection with encephalitis, which is characterized by several ring-enhancing skin lesions. This is definitely what is the organism which is going to strike us immediately? Toxoplasma encephalitis. Okay. And he's not taking his antiretroviral therapy on a regular basis. Okay. So, our diagnosis is Toxoplasma encephalitis, and is the CSF findings likely mode of, okay, let's answer this question. What is the likely mode of transmission of the organism causing this patient's symptoms and MRI findings? Can you think of what are the modes of infection with Toxoplasma? There are so many of them. One of the modes is, always remember, in Toxoplasma, man is an accidental and a dead end host. Okay. So, definitive host is, man is the intermediate host, man is the accidental host, or man is the dead end host. These are all applicable to human Toxoplasma infection. Okay. Now, definitive host is cats. So, cats are going to pass out in their feces unsporulated oocysts, and this is going to sporulate in the environment in a couple of days, and these are ingested by these animals. So, ingestion of poorly cooked beef or poorly cooked pork, which is harboring tissue cysts, or contaminated cat feces, contaminated food or water, or direct contact with, while cleaning the cat litter box, you accidentally put your fingers to the mouth. It can also be transmitted via blood and to the fetus across the placenta. So, the most likely mode of transmission in this patient, what was it? It was ingestion. Ingestion. That's the most common mode. Ingestion of so many, could be poorly cooked meat or by handling cat litter box and so on. Okay. So, serum findings in this patient will be IgG. So, how can we confirm that this is Toxoplasma? Anti-Toxoplasma antibodies are detectable in the serum, and these are of IgG class. Absence of these antibody will tell you this is going against a diagnosis of Toxoplasma encephalitis, right? So, HIV patient with ring enhancing lesions in his brain, and he's having seizures, head blurring, vision, etc. Think of Toxoplasma. Had it been neurocystic sarcosis, we would have seen both ring enhancing and non-enhancing lesions in the brain on MRI, right? Now, what is the treatment of this patient of Toxoplasma encephalitis? Pyrimethamine with sulfadiazine. That's the drug of choice. Okay, with that, we've done lots of CNS disease due to infectious agent. We now move on to gastrointestinal disease due to infectious agents. A 12-year-old female is brought to the emergency because of bloody diarrhea for the past 3 days. Her parents report she had gone for a party a week back where she had fried rice, pastries, hamburger and cola. Her temperature is 99.99, pulse is 125, respiratory rate is normal, blood pressure is normal. Physical examination shows petechiae on the extremities and the chest. Lab studies are as follows. There is anemia, there is mild leukocytosis, platelets are markedly reduced, the prothrombin is in normal range, the fibrinogen is in the normal range. Serum creatinine is elevated, blood urea is elevated. So first of all, what is the diagnosis? The first thing that strikes us is this patient has bloody diarrhea. So we're going to think of an invasive cause of diarrhea. Invasive diarrhea. This patient has blood in stools. What do we call it as? Dysentery. So what are the causes of invasive diarrheas which lead to dysentery? We think of bacteria like Shigella, enteroinvasive Escherichia coli. So in India, Shigella is the most common cause of dysentery. Others include enteroinvasive E. coli, enterohemorrhagic E. coli. These are the most common causes. Then, of course, yes, please include Campylobacter also. Campylobacter, Vibrio parahemolyticus, non-typhoidal salmonellas and Yersinia enterocolitica. These are less common. I mean less common causes of bloody diarrhea. I'm not saying they don't cause, they are less common causes of diarrhea. Non-typhoidal salmonellas is a very, very common infection otherwise, right? Amongst the parasites which can cause invasive diarrheas are Entamoeba histolytica and Balantidium coli. But even schistosomes during the intestinal phase of infection by the adult worms, even they can manifest as dysentery. Okay, keep that also in your mind. Right, keeping these in our mind, let's move on to our further diagnosis. So, bloody diarrhea, we are going to think of these causes. And this patient has ingested such and such food. But what is there to register amongst the symptoms are the petechiae, so hemorrhagic manifestations, the thrombocytopenia and the anemia with elevated renal renal failure. So, what are we going to think of? This is a bloody diarrhea with hemolytic uremic syndrome, HUS, bloody diarrhea with HUS. And what are the infectious causes of bloody diarrhea with HUS? In our country, we are going to think of Shigella or we are going to think of enterohemorrhagic E. coli because these are the only ones which produce the Shiga toxin or the Shiga-like toxin or which is able to bring about hemolytic uremic syndrome. Okay, so most likely food that was implicated. What did the child have in the party? What all food did she have? Fried rice, pastries, hamburgers. This is the implicated food in this. Okay, right. So most likely food implicated is contaminated, poorly cooked hamburgers. So what is the pathogen? Is it Shigella or it is enterohemorrhagic E. coli? It is EHEC, which is the cause of bloody diarrhea in this child. Because enterohemorrhagic E. coli are a zoonotic infection. The reservoir are especially cows, GI tract of cows. What are the important virulence factors? They have a locus of enterocyte effacement plasmid. And this brings about the attachment effacement effect on the intestinal mucosa. And the other one is the phage-mediated virotoxin, also called as the Shiga-like toxin. Now, this Shiga-like toxin, once it is secreted by the bacterium, it can disseminate via the blood and it can cause hemolytic uremic syndrome in the form. So, what it does is it inhibits protein synthesis. It inhibits protein synthesis and the site of action is the endothelial cells. And what is the receptor for this toxin? It is the GB3 receptor. So once this toxin is secreted by the bacterium, it disseminates via the blood and finds its receptors on the glomerular endothelial cells, leading to the inhibition of protein synthesis in the endothelial cells and thereby necrosis of the endothelial cells. That's a beautiful picture showing us what is the mode of action. So that's our toxin, and it is acting on the glomerular endothelial cells. Once they undergo necrosis, what is going to happen? There is activation of the coagulation pathway. So there is consumptive thrombocytopenia. There are lots of clot getting formed. Obviously, the renal function is compromised and the RBCs are passing through these partially clogged blood vessels. There is going to be shearing of their side, leading to microangiopathic hemolytic anemia. So ATM, acute renal failure, consumptive thrombocytopenia and microangiopathic hemolytic anemia. That's our triad of hemolytic uremic syndrome. So how will you further work up this patient? On peripheral blood smear, you're going to see schistocytes. I'll show you the picture shown in the question related to it. Stool you're going to transport. You're going to transport the stools. What is the universal stool transport medium? The Carey-Blair medium. On stool microscopy, we are going to see lots of WBCs as well as RBCs. That indicates invasive diarrhea. Stool culture will be done on McConkey, and we are going to see lactose fermenting colonies on McConkey. And now, once we have got our lactose fermenting colonies, we can prove this is E. coli, which is the cause, by putting up the biochemicals that I told you. It is motile or it is oxidase negative, it is indole test positive. Now, confirmation of enterohemorrhagic E. coli is done by detection of the toxin in the stool. So, virotoxin detection in the stool. And that is done by a special tissue culture assay, or we can detect it directly by PCR. Okay. Management, symptomatic treatment of this child. Meaning, you are not going to give antibiotics in this child who is having EHEC infection, because it has been seen that administration of antibiotics increases the cytotoxic effect of the Shiga-like toxin or increased chances of hemolytic uremic syndrome or more severity of the hemolytic uremic syndrome. So don't give antibiotics in this patient of EHEC diarrhea. That's our special medium which detects a special serotype of enterohemorrhagic E. coli, which is E. coli O157H7. So this is sorbitol McConkey medium. On this medium, it produces sorbitol, non-sorbitol fermenting colonies. Non-sorbitol fermenting colonies, which are pale colonies. Can you see those? Some of them are bright pink. These are sorbitol fermenting, and these are non-sorbitol. So E. coli O157H7 does not ferment sorbitol. Rest of all E. coli ferment sorbitol, producing those bright pink colonies. So this is a special medium which helps us to identify this special serotype of EHEC. Okay, so we've talked about bloody diarrhea, in other words, dysentery. Let's talk about other causes, other types of diarrhea that you can get questions on. If we have a question which is talking about rice water stools or severe watery diarrhea with effortless vomiting, with rapid dehydration, patient presenting with sunken eyes within a day, and washerman woman hand, metabolic acidosis leading to shock and death, what is our likely diagnosis? This is cholera. What is the etiology of cholera? It is Vibrio cholerae. Is it all Vibrio cholerae? No, it is O1 and O139, because these are the only two serotypes which produce the cholera toxin. Okay. Now let's work up this patient. We're going to transport this patient's stool in either Venkatraman Ramakrishnan medium, autoclaved seawater, or Carey-Blair medium, or we can use alkaline peptone water. Venkatraman Ramakrishnan, autoclaved seawater, Carey-Blair and alkaline peptone water. On microscopy, we cannot appreciate any WBCs, any RBCs, because this is not an invasive diarrhea, it's a toxin-mediated diarrhea. Then we are going to be able to appreciate the darting motility or the shooting star motility. And the microbiologist can rapidly do a diagnosis, just place a drop of the patient's stool and you're observing this darting motility under the microscope, add a drop of the antiserum. The vibrios will be immediately immobilized. The gold standard method for diagnosis is culture. Okay. On McConkey, they produce non-lactose fermenting colonies, and on TCBS, thiosulfate, citrate, bile salt, sucrose medium, they produce yellow colored colonies, meaning they are sucrose fermenting. So, Vibrio cholerae is a sucrose fermenter. Serotyping can be done, so whether it is O1 or O139 can be done by slide agglutination test. You want to know which serotype is the culprit organism. Management of this patient: assess the hydration status of this patient by the skin turgor, the thirst, the mentation, the pulse, and accordingly give either parenteral or oral fluid replacement. Antibiotics, what is the antibiotic of choice? Doxycycline. This should be given in moderate or severe disease because it reduces the duration and it also reduces the severity of the disease. Reduces duration and severity of the cholera. Okay, let's take a question. A previously healthy 11-year-old girl is brought to the hospital with a history of intestinal infection with cramping and watery stools for the last 3 days, and now she has started to pass blood per rectum. So we're looking for dysentery causes. She is hospitalized for moderate dehydration. She is noted to have a heart rate of 90, blood pressure slightly on almost normal, respiratory almost normal. Over the next 6 hours, she has a reducing urine output with blood urea nitrogen rising to 54. Total blood count reveals RBC count of 3.5 million. So almost normal, platelet slightly reduced, platelet count of 80,000, again thrombocytopenia. Peripheral blood smear is shown in this picture. What are we seeing? These are the schistocytes. Infection with which of the following is most likely responsible for this syndrome? Clostridium perfringens, Shigella dysentery, enteroinvasive E. coli, Salmonella typhi. So a bloody diarrhea followed by hemolytic uremic syndrome. Our likely organism is Shigella dysentery. Okay. Next question. A patient is brought to the emergency with complaints of severe watery diarrhea and vomiting for the last several hours. On physical exam, the patient is lethargic, dehydrated, BP is on the lower side, pulse is rapid, he has dry mucous membranes, poor skin turgor and reducing urine output. He is immediately admitted and started on IV fluids. The nurse shows the patient's stool to the doctor as shown in the figure. So what are these stools? These are the typical rice water stools. Which of the following is correct about the etiology? So we have to find the correct statement. Causes a net efflux of ions and water from tissue into the lumen of the large intestine. Now here this statement is incorrect. It is the small intestines which are the site of action of the cholera toxin. Causes destruction of the intestinal mucosa. There is no destruction of the mucosa. It's a toxin-mediated diarrhea. Produces its effect by stimulating adenyl cyclase activity in mucosal cells. This is absolutely right. Cholera toxin, what is the mode of action? It increases cyclic AMP by increasing the activity of adenyl cyclase, okay, by acting on the G stimulatory protein. There are two proteins, G stimulatory and G inhibitory. So what is the site of action is? It stimulates it brings about an ADP ribosylation of the G stimulatory protein, thereby leading to increased cyclic AMP by increased activity of adenyl cyclase. So this is our correct statement. Prefers acidic pH of growth. This is incorrect because all Vibrios are alkaliphiles. Okay. So what are the forget-me-not points about Vibrio cholerae? It is an alkaliphile. The optimum pH of growth is 8.2 to 8.4. It is one of the otherwise all Vibrios are halophilic. They require salt to grow, but two species, Vibrio cholerae and Vibrio mimicus, these two species are non-halophilic. The reservoir for all Vibrios in the inter-epidemic period is seawater where they exist as viable but non-cultivable. So that's the state where they are live. It's basically a low metabolic rate state. Virulence factors of Vibrio cholerae, extremely important. Sheathed flagellum, which is a monotrichus present at one pole. Toxin co-regulated pili, these are pili which help in adhesion to the small intestinal mucosa. The cholera toxin, what is the receptor for cholera toxin? GM1 ganglioside. That's the receptor. And what is the mode of action? We've already learned, increases cyclic AMP by increased activity of adenyl cyclase. There's another minor toxin that it secretes, the zonula occludens toxin, which disrupts the tight junctions. Tight junctions are also called as zonula occludens. So that further causes the diarrhea. Okay, contributes to the diarrhea. Okay, another condition that you can be asked regarding diarrheas is there is a person who has traveled to a third world country or a resource poor country, and patient then presents with watery diarrhea and cramps. So what is our diagnosis in that case? It is a traveler's diarrhea. And what is the most common cause of traveler's diarrhea? It is enterotoxigenic Escherichia coli, ETEC, the most common cause of traveler's diarrhea. What are the important virulence factors behind the traveler's diarrhea? Special proteins present on its outer membrane, which are called as colonization factor antigens, which help in adhesion to the small intestinal mucosa, and it secretes two toxins, the labile toxin and the stable toxin. Labile toxin, its mechanism of action is absolutely similar to the cholera toxin, increases cyclic AMP. The stable toxin, it increases cyclic GMP. Okay, an easy way to remember is, so this is increasing cyclic AMP, that labile is in the air, stable is on the ground. Labile in the air, so increases cyclic AMP, stable toxin increases cyclic GMP, right? So those are the two toxin it secretes. So how do we diagnose it? We can detect the toxin in the stool. Generally what are used are either ELISA or PCR. There are many fancy named tests which are no longer done. We have such easy and rapid methods for diagnosis of the detection of the toxin in the stool. Basically, it is rehydration, maintenance of the fluid and electrolytes, and we can give the antibiotic, either one of the fluoroquinolones or we can give fidaxomicin. That's the treatment of traveler's diarrhea. Now, what is the differential diagnosis of traveler's diarrhea, also called as Turista, ETEC? So, amongst the bacteria, if we talk about, it is ETEC, enteroaggregative E. coli, Campylobacter, or rather before Campylobacter, I should write Shigella, and the non-typhoidal Salmonellas. These are bacterial causes of traveler's diarrhea. Then we have protozoal causes of traveler's diarrhea, and these include Giardia, Cryptosporidium, and Cyclospora. And we have viral causes. Amongst the viruses, it is noroviruses. And which is the norovirus we know about? Norwalk. Right? The most common, of course, remains ETEC. Other important causes include EAEC and Shigella. Okay, let's do a few questions. A 29-year-old CEO of an IT startup returns to Delhi from Bangladesh. 2 days later, he reports to the hospital with complaints of nausea, abdominal cramps, frequent passage of loose stools. Okay, so this is definitely traveler's diarrhea. He denies seeing blood in stools. There is no invasion. It's a toxin-mediated diarrhea. He denies recent antibiotic use. We could think of antibiotic-associated colitis. Microscopy of the stools shows many WBCs and RBCs. Now, here is the trick. This is a trick question. Here we have a traveler's diarrhea with no blood per rectum seen, but on microscopy, we are seeing many WBCs and RBCs. Okay. So, most likely organism is not going to enterotoxigenic E. coli. It is going to be Shigella dysentery, which is one of the causes of traveler's diarrhea, and it causes invasive diarrhea. A 25-year-old American tourist drinks a glass of fresh fruit juice from a street vendor while on a holiday in India. 3 days later, he develops watery diarrhea with abdominal cramps. He reports to the OPD, his vitals are stable. Physical examination is notable for dry mucous membranes. He has no abdominal tenderness or rigidity. The stool guaiac test is negative. That means there's no blood in the stools. That's an indirect way of saying there is no blood in the stools. Following lab investigations, E-tech is diagnosed as the culprit organism. Which of the following is correct about E-tech? Produces a toxin that ADP ribosylates a large G-stimulatory protein. This is absolutely right. That's the action of labile toxin. It has a small infective dose. That is incorrect. It is mainly transmitted via contaminated fingers and fomites. This is also incorrect. Only those pathogens which have a very small infective dose like Shigella or enterohemorrhagic E. coli or Giardia, these can be transmitted via contaminated fingers and fomites. It has P. pili. P. pili are the virulence factors of the uropathogenic E. coli, not E-tech, right? So, remember for get-me-not points about E-tech, they have a very, very large infective dose. More than 10 raised to power 9 bacteria at least must be ingested. The virulence factors, colonization factor antigens, and plasmid-mediated labile toxin, which acts by increasing cyclic AMP, and plasmid-mediated stable toxin, which acts by increasing cyclic GMP. Labile in the air, stable on the ground. Okay, another condition or another state vignette that you can be given is a vomiting and nausea manifesting within 6 to 8 hours of the particular food. So what are we thinking of? We are going to think of short incubation food poisoning. And there are two differential diagnoses of short incubation food poisoning. One is Staph aureus, which secretes many antigenic types of enterotoxins. Okay, so what are the foods implicated in Staph aureus food poisoning? It could be meats, salads, egg salad, chicken, potato, etc., bakery products, pastries, eclairs, cream pies, and milk products. And these are containing preformed toxins. So basically the food has been prepared, it gets contaminated by a Staph aureus carrier, the food is left outside and Staph aureus secretes these enterotoxins. The food may be heated before it is ingested, but these enterotoxins are heat stable. Okay, and then what is their mode of action? They are acting by stimulation of the vagus and the vomiting center, causing vomiting, nausea, occasionally diarrhea, but fever is generally absent. The other cause of short incubation food poisoning is Bacillus cereus, and here generally the implicated food is fried rice or Chinese rice with preformed emetic toxin, which is also called as cerulide, C-E-R-U, cerulide, okay, whose mode of action is absolutely same as the Staph aureus enterotoxins. A group of 20 friends had a late night party at a restaurant. 2 of them stopped back to eat pastry. What are we going to think of? Staph aureus. Only those who ate the pastry manifested with nausea and vomiting early next morning. So within a few hours, the patient is presented with symptoms. What is the likely etiology? Undoubtedly, it is enterotoxin of Staphylococcus. Okay, another vignette can be talking about recent use of broad spectrum antibiotics followed by watery diarrhea episodes and abdominal cramping and bloating. What is the likely causative agent? It is Clostridium difficile. It should not be Clostridium difficile, it should be Clostridioides difficile. But to be safe, I've just written C. difficile. So what is it causing? Clostridium difficile infection, a milder infection also called as antibiotic associated colitis, and a severe disease called as pseudomembranous colitis. So what is the pathogenesis of this Clostridium difficile infection? There's a history of broad spectrum antibiotic intake like cephalosporins, second or third generation cephalosporins, or it could be ampicillin, amoxicillin, clindamycin, or fluoroquinolones, which lead to destruction of the normal gastrointestinal commensals, as a result of which Clostridium difficile gets an opportunity to germinate, and then it secretes the toxin A and toxin B. Normal gastrointestinal flora generally inhibits the germination of Clostridium difficile. These toxin A and B, what is their mode of action? They are basically the glucosyl transferases. So we have certain proteins which are responsible for maintaining the normal actin cytoskeleton, which are Rho, RAC and CDC42. What do these toxin of Clostridium difficile do? They glucosylate them, as a result of which their action gets abrogated, and this leads to dysregulation of the actin cytoskeleton and apoptosis of the intestinal mucosal cells, and manifesting with watery diarrhea, occasionally fever with abdominal cramps. How do we diagnose Clostridium difficile infection? Either we detect the organism in the stool, we can do the stool culture on CCFA medium, or we can detect a Clostridium difficile specific glutamate dehydrogenase by ELISA. But this tells us that the organism is present in the stool. It does not define, yes, this is producing the toxins in the stool. So you can do, next step is detect the toxins in the stool. So that can be done either by tissue culture assay, or it can be done by ELISA, or it can be done by PCR for the genes responsible for these toxins. Colonoscopy, it demonstrates the yellowish white pseudomembranes, which are basically composed of the necrosed intestinal mucosal cells along with fibrin, along with WBCs. Okay. So if we are asked what is the gold standard method for diagnosis of Clostridium difficile infection, it is basically culture followed by toxin detection. Culture followed by toxin detection. That is the gold standard method for diagnosis. Those are the pseudomembranes. Treatment of Clostridium difficile infection, first of all, ask the patient to stop eating those culprit antibiotics. And if the symptoms still persist, now the drug of choice is fidaxomicin, okay, preferred over oral vancomycin. If it's a fulminant disease in the form patient is having some intussusception, toxic megacolon, there is paralytic ileus, then we will combine vancomycin orally along with IV metronidazole. If there are multiple CDI recurrences, we can consider fecal microbiota transplant. Okay, sometimes we have a vignette talking about ingestion of oysters or shellfish, followed by watery diarrhea and abdominal cramps. What is the likely etiology? It is Vibrio parahemolyticus. Vibrio parahemolyticus. What are the forget-me-not points about this organism? It is peritrichous on solid media and monotrichous on liquid media. It shows swarming just like Proteus, and it has a special phenomenon, Kanagawa phenomenon, on Vagatsuma agar. Kanagawa phenomenon is basically on Vagatsuma blood agar, which is human blood agar. Blood agar prepared using human RBCs. On this medium, the pathogenic strains are hemolytic, the non-pathogenic strains are non-hemolytic. And I missed out one point. it can tolerate up to 8% of salt. 8% of salt concentration it can tolerate. Okay. The drug of choice for this diarrhea is doxycycline. What is the differential diagnosis of Vibrio pylori? Meaning, if oysters or shellfish intake, do we have a differential diagnosis? Yes, we do. We have the Norwalk virus. Even Norwalk is associated with seafood ingestion. Sometimes we are given a clinical vignette, patient has come with such and such kind of diarrhea, and the clinching point or the buzzword out there is the medium that has been used to isolate the organism. So, commonly you will get a question talking about the culture was positive on Bacillus medium or Scirrhos medium. What is the organism we are going to think of? Campylobacter. Okay, forget-me-nots of Campylobacter, it's a gram-negative curved rod, just like Vibrios are gram-negative curved. Sometimes it can be spiral, or it's sometimes, in the question it is written as gull wing forms are seen. Gull wings are like this. Okay. It has polar flagellae, which may be, either a single flagellum at both the poles or a tuft of flagellum at both the poles. Very important, it is microaerophilic and its optimum temperature of growth is 42 degrees Celsius. It is normally present in the GI tract of several domestic animals, so it is a zoonotic infection, and the most common food that is implicated with campylobacteriosis is ingestion of contaminated, poorly cooked poultry. And a very important complication, neurological complication of campylobacteriosis is Guillain-Barré syndrome. Keep that in mind, very important. Okay, let's do a couple of questions. A 70-year-old man is hospitalized for an infection treated with clindamycin. We are thinking of antibiotic-associated diarrhea. Patient improves, returns to his nursing home, but 2 weeks later presents with loose mucoid stools. Diarrhea is voluminous. He is having severe abdominal pain. Sigmoidoscopy of his colon reveals yellow-white plaques. What is incorrect about the condition? Of course, this is CDI. It is toxin mediated. Absolutely right. Oral fidaxomicin is used for treatment. Yes. Can be confirmed by using IgM assay. There's nothing like that. We know the methods for diagnosis. Prove the organism is present in the stool. Prove that it is producing those toxins. And what are the option D? Pseudomembranes consists of leukocytes, fibrin and cellular debris. Yes, that is also absolutely right. So, the incorrect statement is option C. 8 of 10 family practice residents who had a potluck 4 days ago now have diarrhea with abdominal cramps, general malaise and fever ranging from 37 to 38. Stools from 3 residents are blood tinged. Okay, it's a bloody diarrhea. Laboratory studies revealed that the causal agent was a microaerophilic gram-negative curved rod with polar flagellae, all the characteristics of Campylobacter mentioned, that grew on a special medium at 42 degrees Celsius. What are those 2 special media we talked about? Scirrhos medium and Bacillus medium. Might have heard of Campylobacter also. The original contamination probably was found in which of the following? As I said earlier, the most common implicated food is contaminated poultry. Fatty, greasy, foul-smelling stools associated with bloating, abdominal distension, sometimes there is a history of camping where the patient ingested human feces contaminated water. What is the likely diagnosis? Fatty, greasy stools. This is definitely giardiasis. Okay. So that's what it looks like on stool examination. What are the forget-me-not points? Giardia, a very, very common infection. In fact, the most common parasitic infection in the world. The infective form is the quadrinucleate cyst, and it converts into the trophozoite, which has a typical falling leaf motility. This trophozoite has four pairs of flagellae. It is binucleate. What is the habitat? The most common habitat is the duodenum. And pathogenicity, it adheres via the sucking disc, which is present on the ventral aspect and leads to malabsorption and steatorrhea. Okay, very important. Sometimes it may be mentioned string test was positive. String test is you ask the patient to ingest the string which is having a gelatin capsule at the lower end. You just do it for getting a sample of the duodenal contents. So entero test, and gold standard for diagnosis is PCR. Okay. Treatment is tinidazole. Okay. Coming to another very commonly asked question, HIV patient presents with profuse watery diarrhea with abdominal cramps. Immediately we are going to think of the most common causes, that is the coccidian protozoa, which are these Cryptosporidium hominis and Cryptosporidium parvum, Cyclospora cayetanensis and Cystoisospora belli. These are the three common causes of diarrheas in HIV, most common amongst which is Cryptosporidium. The infective form in all of them is the sporulated oocyst. Sporulated oocyst. Now, I've made this table for you all to compare, because this is commonly mentioned in the questions asked regarding diarrheas in HIV. What is the now these oocysts which are passed out in the patient's stool sample, these are demonstrable by the modified acid-fast stain or the Quignon stain. You know, you use a lower concentration of sulfuric acid as the decolorizer. So, size of the acid-fast oocysts tells you what is the likely organism. So, if you've arranged these three, I've arranged them in the alphabetical order, CR, CY, C and CYS. Okay, alphabetically if you arrange them, their size keeps on increasing. So, 4 to 5 microns, then 8 to 12 microns, keep on doubling, you know, and 20 to 33 microns. The oocysts can be directly seen under the fluorescent microscope. In case it is cyclospora, their maximum autofluorescence is seen, slightly less with cystoisospora. Some people say, some people don't, that Cryptosporidium oocysts are autofluorescent. Okay, now coming to sporozoites which are seen. What are these cysts seen in the oocysts seen in the stool sample? Are they sporulated or not? They are only sporulated in case of Cryptosporidium, not in the other two. Okay, so oocysts don't contain sporozoites in case of Cyclospora and Cystoisospora. So that is the reason, since the sporozoites are already present in case of Cryptosporidium infection when they are passed out in the feces, that is why they can cause external auto-infection. Treatment, cryptosporidiosis treated by nitazoxanide. The other two are treated by cotrimoxazole. Let's do a question. A 45-year-old male with HIV presents to the emergency with complaints of profuse watery diarrhea, abdominal cramps and fever. So it's an HIV patient with watery diarrhea. He's not been taking his ART regularly, has a CD4 count of 50. He's weak, dehydrated with tachycardia, lower BP. His abdomen is tender on palpation. There are hyperactive bowel sounds. Stool analysis reveals acid-fast round structures. What is the likely cause of diarrhea? Here the size. So first thing is acid-fast. So immediately we're going to think of coccidian protozoa. The size is not mentioned. So what are we going to think of? What is the most common amongst them? So we are going to mark Cryptosporidium as our answer. Okay. Right. Forget-me-not points about Cryptosporidium. There are two species. Hominis is much more common than parvum. The word hominis is telling us humans. So humans are the sole reservoir. This has an animal reservoir. Anything that has an human reservoir, obviously it's going to be very easily transmitted. It has a very small infective dose. It's a zoonosis in case of Cryptosporidium parvum. There is internal autoinfection as well as external autoinfection. External I've already explained, because the thick-walled sporulated oocysts are passed out. They are already containing the sporozoites. But what is internal autoinfection due to? Please see this. When the oocysts are being formed, there are two types of oocysts being formed in the life cycle. Thin-walled oocysts are already containing these sporozoites. They immediately, within the GI tract itself, they are releasing the sporozoites, causing internal autoinfection. And these are the external autoinfection, thick-walled oocysts in case of Cryptosporidium. What's the treatment? Nitazoxanide. Let's take up another vignette. An 8-year-old boy is brought to the emergency with a 4-day history of abdominal pain with diarrhea. 3 weeks ago, he had traveled to the Philippines and went swimming at his grandparents' lake house. Physical examination reveals a temperature of 101.2, tenderness on palpation of the right upper quadrant, serum bilirubin, SGOT, SGPT are normal. A CBC shows elevated eosinophils. Whenever this is mentioned in the vignette, it is more likely a hinting to a parasitic infection. Microscopic analysis of the stool sample reveals rounded eggs approximately 100 microns with a small knob. What is the likely infection? So here the biggest hint to us is that swimming. Patient has come with abdominal pain and diarrhea with elevated eosinophil, and the biggest hint is rounded eggs with a small knob. What do we think of? Schistosoma japonicum, which is acquired via penetration of the skin during swimming by the cercariae. Okay, so that's the egg that was likely seen. That's the rounded egg, about 100 microns in size. Now, Schistosoma japonicum is mainly reported from China, Indonesia, and the Philippines. That's where the child had gone to his grandparents. Okay, so this is the diagnosis becomes intestinal schistosomiasis. So once the cercariae penetrate the skin, please see this life cycle to be able to understand what the patient manifested with. The cercariae penetrated the skin while swimming. They converted into schistosomulae, entered the circulation, reached the heart, the lungs, and finally they entered the systemic circulation, reached the plexuses. In case of Schistosoma mannsoni and japonicum, mesenteric plexuses. In case of Schistosoma hematobium, the vesical plexus. Now, once these reached the respective sites, they matured into the adult worms. Now, once the adult worms localize in the plexuses, after some time, they start to lay the eggs. And in response to the antigens released by the eggs, there is an inflammatory response manifested, and that is called as the intestinal schistosomiasis. Patient is going to come with, severe abdominal pain with diarrhea in even dysentery. That's the intestinal schistosomiasis. And of course, the diagnosis can be done by demonstrating those eggs in the stool. In case of mannsoni, we would have a lateral spine. It's an elongated egg. Okay, so that was our diagnosis. How did the infection occur? Skin penetration by cercariae while swimming. What are the important complications? A chronic infection with either of Schistosoma japonicum or mannsoni in the mesenteric plexuses can lead to hepatosplenic schistosomiasis. So, as the eggs keep on getting laid, there is inflammatory response, there is fibrosis gradually occurring, and that is typically manifested with portal hypertension manifestations. Okay, so patient will come with splenomegaly, esophageal varices, ascites, hypoalbuminemia, etc. That's one complication. Another complication is egg embolism. The eggs can embolize and can lead to neurological deficits. Not to forget that there is a disease called as Katayama syndrome or Katayama fever. That is when the eggs are laid for the first time in the plexuses. The patient is going to come with a serum sickness like illness that is called as Katayama fever. What is the drug of choice for schistosomiasis? It is praziquantel. Okay, intestinal schistosomiasis can also be due to Schistosoma mannsoni, which is endemic to Africa, Middle East, Caribbean, Brazil, Venezuela, etc. None of the schistosomes are fortunately found in our country. So, patient will generally have a history of travel to either of these locations or the endemic areas. Forget me not about schistosomes. All schistosomes are the exceptions, that they are the only trematodes which have separate sexes, that is, they are dioecious. They are the only trematodes which have only one host in their lives, intermediate host in their life cycle, and that is the snail. Rest of trematodes will have freshwater fish or freshwater plants as their second intermediate host. The mode of infection is skin penetration by Cercariae, generally while swimming. And schistosoma hematobium is associated with, because it's found in the vesical plexus, with squamous cell carcinoma of the bladder. So we have a baby who's crying. Why did you not talk about infantile diarrhea? Of course, we can never leave the babies behind. They are our beloved ones. So what are the causes of infantile diarrhea? Most important cause is the rotaviruses, which belong to the reoviruses, reoviridae. And unique property of reoviruses is that these are wheel-shaped viruses, and they are naked, meaning non-enveloped viruses, and have a unique genome. It's a double-stranded RNA genome which shows many segments, 10 to 12 segments. Rotaviruses have 11 segments in their genome. And any virus which has a segmented genome, what can it show? Genetic recombinations. Recombinations, just like influenza virus. Rotaviruses have a special non-structural protein 4, NSP4, which is an enterotoxin. A unique virus having an enterotoxin, and diagnosis is generally done by detecting the antigen in the stool. It can be detected by ELISA or by latex agglutination or by immunochromatographic tests. Okay, so we've discussed some CNS infections, we've discussed some gastrointestinal infections. Just finishing off GI infections, in questions what can be done, what is the biggest hint to you, can give you an idea what is the cause of that infection. If in stool it is written as watery diarrhea, think more often of a non-invasive cause of diarrhea. If it's a bloody diarrhea, think of an invasive cause. Rice water stools, cholera, fatty diarrhea, think of giardia. Sometimes the incubation period is the biggest hint, short incubation. Food is the hint, seafood, Vibrio parahemolyticus, pastries, Staph aureus, fried rice, it's Bacillus cereus, beef or hamburgers, think of enterohemorrhagic E. coli. Sometimes the culture medium is mentioned, Campylobacter, or it may be mentioned for some other bacterium. Stool microscopy, if it's showing WBCs and RBCs, think of invasive cause of diarrhea. Bacteria sometimes are mentioned. These kind shapes are written, spirals are written, or we are seeing gull-wing forms, think of the respective. Sometimes you can be given eggs or oocysts are seen. Then sometimes the special complication, HUS of Shigella EHEC, or Guillain-Barré syndrome of Campylobacter, sometimes bacteremia may be mentioned. That's a very rare complication of Salmonella species. Or sometimes it can be a liver abscess. What is that organism which causes a GI infection and is associated with liver abscess? I didn't talk about it. Of course, it is Entamoeba histolytica. Okay, let's do a few clinical vignettes of pneumonias. An 82-year-old female presented to the emergency with complaints of fever, cough, headache for the past 5 days. She endorses 5 episodes of diarrhea over the last 2 days. The patient's husband notes that she has been confused for the past 1 day. She has smoked 1 pack per day for the last 20 years. Past medical history includes hypertension, type 2 diabetes. Temperature is raised, blood pressure is almost normal, respiratory rate is rapid, pulse is normal. X-ray chest shows unilobar consolidation in the right lower lobe with a background of bilateral interstitial infiltrates. Lab findings are as follows: leukocytosis, platelets slightly, almost normal, sodium is reduced, potassium is normal, sputum culture is negative on routine culture media. Now, this is the biggest problem with our case. Sputum culture comes negative on routine culture media. So, what are we going to think of? We are thinking of some pneumonia, considering all that consolidation they talked about, but it is an atypical pneumonia. Or let's say pneumonia due to an atypical pathogen. Pneumonia due to an atypical pathogen. What are atypical pathogens? They don't grow on routine culture media and they are generally not demonstrable by the Gram stain. Okay. So, we'll come back to this clinical vignette later. Let's talk about what are the various causes of pneumonia. Talking about typical organisms. Typical organism which will easily grow on routine culture media, will be seen on Gram stain, of the sputum specimen or other respiratory tract specimens will be Streptococcus pneumoniae, most common cause of community acquired. In fact, let me go back to that. I would like to redefine that. There is no history of hospitalization. So what will I call it as? It's a community acquired pneumonia. Community acquired pneumonia. No history of contact with the hospital. Okay? Community acquired pneumonia due to an atypical pathogen. Let's come back now. So most common cause of community acquired pneumonia is Streptococcus pneumoniae. Next most common would be Hemophilus influenzae. Other typical pathogens which are seen occasionally include Staph aureus, Klebsiella pneumoniae and Pseudomonas aeruginosa. Now let's consider them one by one rapidly. Streptococcus pneumoniae, the most common cause of community acquired pneumonia, and generally 2 or more risk factors are present in the patient. So what are these risk factors? Smoking, alcoholics, diabetes, any chronic lung, liver, heart or kidney disease. I forgot, it's not mentioned here. Elderly is over 65 years. Recent viral respiratory tract infection, malignancies, HIV infections. Yes, even in HIV infection, Streptococcus pneumoniae is a cause of pneumonia. Of course, it's not going to stay behind. Yes, pneumocystis is, but that's an atypical pathogen. Streptococcus pneumoniae says, I'm not going to be left behind. I definitely can cause pneumonia, HIV. C3 deficiencies and asplenia patient. Any asplenia patient would be susceptible to meningococcus, pneumococcus and Hemophilus influenzae. Okay, so either of these 2 or more risk factors would be present. It presents usually as a lobar pneumonia or sometimes as a segmental infiltration. Most common complication is empyema. Diagnosis is done by sputum microscopy and culture. What would it demonstrate? Microscopy would demonstrate the gram-positive cocci in pairs which are lanceolate shaped. And culture would demonstrate alpha hemolytic carom coin colonies. Blood culture are positive in 20 to 25% cases of pneumococcal pneumonia, and a very easy and rapid method for diagnosis of pneumococcal pneumonia is urine antigen detection test. It is, remember, urine antigen detection test is possible in 2 types of pneumonia. One is Legionnaire's disease and the other one is pneumococcal pneumonia. So this is positive. What are the forget-me-not points of Streptococcus pneumoniae? We have already done this. We are not going to repeat them. Let's talk about Hemophilus influenzae, the second most common cause of community-acquired pneumonia. Here, typically it is seen in healthy children, but generally of this age, 4 months to 4 years of age. More often presents as a bronchopneumonia, often associated with lung cysts. Forget-me-nots of Hemophilus influenzae, we have already studied about them earlier when we talked about meningitis. Coming to our next typical pathogen, Staphylococcus aureus. Sometimes it can be a primary infection, meaning no other pre-existing infection, or sometimes it is superimposed on a pre-existing influenza infection. So, influenza we know are typical seasons. At that time, the patient is susceptible to Staphylococcus superinfection. Okay, it can present as a lobar pneumonia or as a bronchopneumonia. Most common cause of pneumonia associated with pneumatoceles is Staphylococcus. Cavitations are commonly seen, empyemas are commonly seen. What is the forget-me-not of Staphylococcus aureus? It is a gram-positive coccus in clusters. All staphylococci are oxidase test negative but catalase positive. Staphylococcus aureus is coagulase test positive. On mannitol salt agar, it forms mannitol fermenting colonies. Mannitol fermenting colonies, which will be yellow in color. All staphylococci have the ability to grow in the presence of 7 to 10% of salt. So that's the salt doing over there, mannitol salt agar. Community-acquired MRSA are notorious in causing pneumonias which are associated with severe necrosis. So lots of multiple cavities may be seen associated with this pneumonia. Most of them are Panton-Valentine leukocidin toxin producing. We've talked about them in our marrow videos. Community acquired pneumonia due to the Friedlander's bacillus. Okay, that's also called as Friedlander's pneumonia. The risk factor typically mentioned in the questions are alcoholics or diabetics. These are the two most important risk factors. This Friedlander's pneumonia mainly affects the upper lobes. Because of an edematous lobar consolidation, the bulging fissure sign is characteristically seen on X-ray. The patient expectorates a blood-tinged sputum described as currant jelly sputum, and there is an increased tendency for abscess formation as well as for pneumatoceles. Okay. Forget-me-nots of Klebsiella pneumoniae, that is the Friedlander's bacillus. It is a member of the family Enterobacteriaceae. All Enterobacteriaceae are catalase positive, oxidase negative. It is a non-motile member which is capsulated. That's why its colonies are highly mucoid. It is lactose fermenting on McConkey medium just like Escherichia coli, and it is urease test positive. Moving on to Pseudomonas aeruginosa. This is a rare cause of community-acquired pneumonia. Generally, it is seen in people who have certain risk factors, especially a structural lung disease like bronchiectasis or COPD or cystic fibrosis. It's the most common gram-negative causing pneumonias in cystic fibrosis patients. And these strains are generally the highly mucoid strains which are producing lots and lots of slime, which is called as alginate. Or it might be this Pseudomonas can cause pneumonias in patients who have used antibiotics in the last 3 months or have been hospitalized in the last 3 months. So if you have a patient coming with pneumonia and he gives this history, I've used antibiotic in the last 3 months, I've been hospitalized in the last 3 months, even Pseudomonas should be one of your differential diagnosis. Forget-me-nots of Pseudomonas, it does not belong to Enterobacteriaceae, it belongs to Pseudomonadaceae family, meaning it is going to be catalase positive and oxidase positive. It is motile and it is a strict aerobe. On McConkey, it is non-lactose fermenting. It is producing that characteristic pyocyanin blue-green pigment. The colonies have a grape-like smell. Selective medium is cetrimide agar. Virulence factors of Pseudomonas: ability to produce slime, lots of pili on its surface, outer membrane proteins, lots of enzymes as well as toxins. Coming to the atypical organisms causing pneumonia. What is atypical? Cannot be cultured on standard media, cannot be demonstrated on gram stain. Out of these, the most common is Mycoplasma pneumoniae. Other causes include Legionella pneumophila, Chlamydia psittaceae, Chlamydia pneumoniae, or Mycobacterium tuberculosis. Of course, in our country, which is endemic, definitely any pneumonia should always be taken as considered as it could be tuberculosis, or it could be Coxiella burnetii, or it could be viruses, right? So, Mycoplasma pneumoniae, a very, very common cause of atypical pneumonia, which is also called as walking pneumonia because it's a slow in onset, slowly progressing type of pneumonia. Patient usually walks up to the doctor, I've not been feeling well for the last so many days, 10 days, 12 days history there will be. Usually affects healthy individuals, generally of younger age group, characteristically associated with an interstitial infiltrates. Very important to remember what could be the complications of Mycoplasma infection. Dermatological manifestation. Think of if you have a patient with erythema multiforme or Stevens-Johnson syndrome, has a history of a dry cough, think of Mycoplasma. Can also have Raynaud's phenomenon, carditis, endocarditis, myocarditis, encephalitis, meningitis, autoimmune hemolytic anemia, renal failure, nephritis. All these are important complications of Mycoplasma pneumoniae. Infection is associated with appearance of cold agglutinins. These are IgM antibodies against human blood group O RBCs. Cultivation. Can Mycoplasma be cultured? Of course it can be cultured. It may be the smallest pathogenic microorganism or bacterium. It is very well cultivable on PPLO medium, pleuropneumonia-like organism medium. most sensitive method for diagnosis is PCR. Treatment can be done with macrolides, fluoroquinolones or tetracyclines. Okay, forget-me-nots, more forget-me-nots for Mycoplasma pneumoniae. It belongs to the class mollicutes of the prokaryotic organism. Mollicutes means soft skin. They don't have a cell wall. So pleomorphic. They have sterols in their cell membrane. No other bacterium has sterols in its cell membrane. But it lacks lots of metabolic enzymes to synthesize sterols, to synthesize purines and pyrimidines. That's why it is called as a fastidious bacterium. It requires special media to grow, which are called as PPLO agar and PPLO broth. Cultivation done, yes, and they form what colonies? Fried egg colonies, or sometimes described as mulberry-shaped colonies. Virulence factors, they have adhesin proteins and they secrete a toxin. Okay. Coming to another atypical pathogen, very important, Legionella pneumophila. It is usually causing pneumonia in people who have certain risk factors. Smoking, chronic renal failure, diabetes, transplant recipients, HIV, male gender, malignancies like lung carcinoma. All these people are at risk factor. Generally, it does not cause in healthy humans. It has an aquatic reservoir. So, natural or artificial aquatic reservoirs. So, mode of infection is generally by inhalation of the aerosols or by micro aspirations of the water droplets. There is no human to human transmission. Okay, Mycoplasma pneumoniae was totally opposites. Very, very easily transmitted from human to human. Now, two very important features of this pneumonia is diarrhea as well as confusion. From the usual symptoms of dry cough with dyspnea and fever, etc., patient characteristically has diarrhea as well as confusion. So, if you remember the first clinical vignette that I read, it was the patient with that female had diarrhea as well as confusion. Now, X-ray chest picture is usually very variable. It could be a patchy or a lobar or a segmental or an interstitial infiltration. And very characteristically, there is hyponatremia, hypokalemia, liver enzymes are raised. Culture, yes, it is a fastidious organism, requires iron and cysteine to grow. And it is cultured on buffered charcoal yeast extract agar. PCR is the most sensitive, and as I said earlier, two pneumonias can be rapidly diagnosed by urine antigen detection test. One was Streptococcus pneumoniae, the other one is Legionnaire's disease. Forget-me-nots of Legionella pneumophila, morphologically it's a gram-negative bacillus which is pleomorphic, facultative intracellular organism. That's one of main reason that beta-lactam antibiotics are ineffective. Beta-lactams are ineffective against Legionella pneumophila. I forgot to mention in Mycoplasma, they don't have a cell wall, they are pleomorphic, and that's the reason the beta-lactams are ineffective against Mycoplasmas also. The most common cause of Legionnaire's disease is serogroup 1, and that is the only one which is detected by the urine antigen detection test. That only can be diagnosed by the urine antigen test. We've already talked about how do we grow Legionella pneumophila. Okay. Right. So, treatment can be done with fluoroquinolones, can be done with macrolides, can be done with tetracyclines. Beta-lactams are ineffective. Okay. Now, coming back to the original question, the patient had cough, headache, diarrhea, confusion, was a smoker, had a unilobar consolidation, bilateral interstitial infiltrates, hyponatremia, and it was negative. So, it was community-acquired pneumonia and it was most likely due to Legionella. So, those were the hints mentioned in this vignette telling you that this is Legionnaire's disease. Okay. The other atypical organisms include Chlamydia pneumoniae, a strict human pathogen, and Chlamydia psittaceae. Okay. Chlamydia pneumoniae is only transmitted from human to human, nothing special about it. Yes, it's a common cause of atypical pneumonia. Chlamydia psittaceae, there is usually a history of exposure to birds. So patient is a pet shop owner or works in an aviary and so on. It's the most common abattoir associated pneumonia. Abattoir is the slaughterhouse. Okay. There is no human to human transmission. So inhalation of the respiratory secretions or other body fluids of infected birds, that's the mode of infection. It can be a variable kind of an infiltration of the lungs, and it very often becomes a septicemia, which can lead to hepatitis, meningitis, endomyocarditis, myocarditis, or it can even lead to glomerulonephritis. When we get a hold of the respiratory tract specimens, the intracellular inclusion bodies are called as Leventhal-Cole-Lilly bodies. These are of Chlamydia psittaceae. But the most common modality used for diagnosis is demonstration of a rise in antibodies. So antibodies rise, and drug of choice is doxycycline. This needs to be given for 3 weeks. Okay. Coming to viral pneumonias. Viral pneumonias, think of respiratory syncytial virus in case it's a young infant. Respiratory syncytial virus is a paramyxovirus. Okay. So RNA viruses, we've already talked about them earlier. Coronaviruses, yes, in today's times, we will always think of coronavirus, COVID-19 as a cause of the pneumonia in this patient. Influenza, influenza patient, it can be a primary influenza pneumonia, or it can be a superimposed Staph aureus or a Streptococcus pneumonia. Metapneumoviruses are recently characterized viruses which cause respiratory tract infections. These are also paramyxoviruses. And of course, a special mention for varicella zoster virus. Sometimes when as adults we develop chickenpox, you can have a patient coming with symptoms of pneumonia. So a pleomorphic rash with macules, papules, vesicles, pustules, scabs, all seen. Along with that, the patient has come with some symptoms related to the chest. Think immediately of varicella pneumonia. It's a very, very severe illness in adults. Okay, you should start the treatment with acyclovir. Let's do a couple of questions. A 62-year-old man described sudden onset chills, fever, cough, and purulent sputum for 2 days. He smoked 2 packs of cigarettes per alcohol, had alcohol binges, has congestive heart failure. So he has pneumonia and he has lots of risk factors. He's acutely ill, had a temperature of 103.4, respiratory rate tachypnea, labored breathing, BP on the lower side, tachycardia. He had decreased breath sounds and density to percussion in the right posterior chest. Which of the following is correct about the most likely etiology? So this is a community-acquired pneumonia with at least 2 risk factors for pneumococcal pneumonia. Obviously, we're going to think of pneumococcal pneumonia because that's the most common cause of community-acquired pneumonia. What is the likely correct statement? It is catalase negative and optogen sensitive. A 16-year-old male has a dry hacking cough with malaise anorexia for the last 8 to 10 days. He presents to the OPD as he is showing no sign of improvement. The X-ray chest shows light diffuse infiltrative pattern. The most likely organism is. Okay, so this is a diffuse infiltrative pattern and the patient is coming with symptoms for the last so many days. It's a dry cough. So most likely organism you're going to think of is now Mycoplasma. Okay, because that's the most common cause of a diffuse type of infiltration in a community-acquired pneumonia. What is the likely correct statement about it? Bacitracin sensitive, catalase negative, gram-positive coccus would give us Streptococcus pyogenes. A non-gram staining bacterium requiring sterols to grow. That is our answer. Mycoplasmas contain sterols in their cell membrane, but they don't have the enzymes to synthesize those sterols. So you need to provide them in the medium for them to grow, right? So that's our answer, option B. A 45-year-old man presents to the emergency with shortness of breath and a productive cough. His sputum is gelatinous and bloody. X-ray chest showed consolidation in the right upper lung field. Gram stain of the sputum showed numerous PMNs and gram-negative rods, forming magenta colonies on McConkey medium. Okay, which of the following descriptions is most likely to fit the patient? When we think of a bloody sputum, it's a productive cough. Most likely, this is going to be one of the typical pathogens. Of course, it's a typical pathogen. A gram-negative rod, which is lactose fermenting, we're going to think of Klebsiella. And that bloody sputum is most likely the currant jelly sputum. Which of the following descriptions is likely to fit this patient? He is most likely an alcoholic. I told you alcoholics and diabetics are prone to Friedlander's pneumonia. You are taking care of a 56-year-old man with a history of hypertension. 5 days prior, he developed acute onset of fever, chills and myalgias. He had a rapid molecular assay for influenza via a nasopharyngeal swab. Okay, PCR was done for influenza and was diagnosed with influenza, initiated on oseltamivir. His fevers improved, he started to feel better, but this morning he developed fever and rigors again, with shortness of breath and purulent sputum production. So it's a superimposed infection on influenza. You collect an expectorated sputum sample, perform a gram stain, visualizing the bacteria shown in the figure. What are we seeing in this gram staining? We are seeing some gram-positive cocci, which are seen in clusters. What is this? This is Staphylococcus aureus. Which of the following is correct about the likely organism? It grows in 8% of salt, it is oxidase negative, it is catalase positive, it is coagulase positive. All of them are correct about Staphylococcus, right? They are all catalase positive, oxidase negative, Staph aureus is coagulase positive, and all Staphylococci are able to grow in 7 to 10% of salt. So this brings us to the end of our microbiology clinical edge discussion. I hope you learnt a lot from it. Thank you so much for watching.